Welcome. I'm Catherine with the Myasthenia Gravis Association. We're excited you have joined us for today's virtual meetup. If you're new here, be sure to check out our website at www.mgassociation.org for a full list of programs. I'm joined today by Al, who is also on our board of directors. Please put any questions in the Q&A and we will monitor them. We're joined today by Dr. Andrew Gordon, who is going to discuss men's health and myasthenia gravis. When Dr. Gordon is finished and the Q&A has wrapped up, please thank everyone for joining. So I'll push it over to you, Dr. Gordon.
All right. Well, thank you so much. Can you hear me okay, hopefully?
Yeah.
All right. Excellent. So I'm Dr. Andrew Gordon from Northwest Neurology here in the Chicago area, in some of the suburbs, Barrington, Libertyville, Rolling Meadows. I'm in Libertyville right now, actually, and just finished seeing some patients, including a new myasthenia gravis patient. And so what we're going to be focusing on here is this is sort of general information, not pertaining to any specific medication, understanding the disease itself, understanding myasthenia gravis a little bit deeper, and the differences based on gender and some other related information, focusing on myasthenia gravis in men. And so the agenda is sort of summarized here. Talk a little bit about what is MG, and I know you know some of this already, and some of it may be review, but hopefully we'll get a little bit more share a little more insight and gain a little more of an understanding. I hope to impart more of an understanding regarding the antibodies, the differences, the different subtypes and different ways MG can present, and some of the differences as well between men and women. And we'll also talk about diagnosis, how the disease is diagnosed, again with some additional insights beyond the basics, hopefully, and how we manage the condition, and ultimately then segueing into different treatment strategies and how that's evolving today compared to 10 or 20 years ago. So myasthenia gravis, of course, is an autoimmune disorder. This means that our body is making antibodies that target self. And in this case, those antibodies are targeting the muscle membrane, which interferes ultimately with neuromuscular transmission. So we don't expect this, generally this disease does not affect the brain, or the esophagus or the stomach or these other organs in the body. It's skeletal muscle. So muscles of the face or eyes, skeletal muscles in the face and eyes. When we say the eyes, we're talking about the muscles that move the eyes, not the eye itself. And the muscles that move our arms and legs, the muscles that move our, that help us swallow, chew, speak, but not the esophagus and stomach themselves. Those are not skeletal muscle structures. And so again, here the antibodies target the muscle membrane, and this interferes with neuromuscular transmission. Just for a little background, in the normal state, and I have a picture there to show you. In the normal state, the spinal nerves that leave our spine and go to our extremities, or the cranial nerves that go to our face and eyes, release acetylcholine in the normal state. Acetylcholine has to bind the receptors, triggering a muscle contraction. So, in our brain, we think we want to move or chew or swallow. We send those signals down, and then there's ultimately the last step is acetylcholine is released from the nerve terminal and has to bind the acetylcholine receptor to trigger a movement. In myasthenia gravis, this process is blocked, right, literally by the presence of antibodies, either to the acetylcholine receptor or adjacent receptors like MuSK or LRP4, which are less common, but also can occur. And these antibodies don't just block, they may bind the receptors, they trigger a lot of inflammation on the receptor site and activate complement. And this is ultimately what drives, receptor loss and destruction of the muscle membrane. MuSK antibodies actually interfere even with clustering, really, of these receptors too, which renders them less effective. So when you have less effective receptors or less of them in myasthenia, it makes it more difficult to trigger a muscle movement, because you need that connection between the nerve terminal and the muscle membrane to move and contract your muscles. There's less safety margin, meaning at rest, we may still be able to activate those receptors and get a muscle movement, but with exertion, where more receptors are needed, more connections are needed for repetitive movement, and for, um, tasks that require more muscle strength. We just don't, in myasthenia, patients just don't have the safety margin. They just don't have enough receptors, enough functioning receptors, if they're not adequately treated, to connect, to make that connection and move those muscles. So that's the underlying reason that we often say this is fatigable. The symptoms in myasthenia are fatigable. When sitting at rest or sitting in a chair, there may be enough functioning receptors to trigger a muscle movement, but with prolonged use, or at the end of the day when the body's more tired, there's less connections and less efficient connections being made at the neuromuscular junction. So that's a little bit of background about what's really happening. And so, from a clinical perspective, this pathophysiology, we would call it, right? Interference in in neuromuscular transmission leads to this clinical symptoms you see there on the screen. Symptoms like double vision, droopy eyes, chewing fatigue, slurred speech and swallowing difficulties. There can be problems breathing, and everybody's different. So there's some patients who have really all of these symptoms and others who have just one or two. And as you may know, the symptoms tend to start with double vision and droopy eyes. And in some cases, it may remain double vision and droopy eyes only. And we call that ocular only, right? When it progresses to these other symptoms, we call that generalized. And it can even include difficulty holding the head and neck up, or holding the core of the body up. Upper and lower extremity weakness can occur. And again, with that weakness in the neuromuscular junction, the symptoms tend to be fatigable. They may be okay when we don't need a lot of muscle strength, but worse when we need more strength, or when we're tired at the end of the day. And we ultimately make this diagnosis both from we have to have some clinical suspicion, and then a blood test is done where we can, of course, check the antibodies. And there's different ways to check the antibodies. There's not a lot of labs that do a cell-based assay, but that is considered a little more accurate than the standard radioimmune assay. But basically, we do have to check antibodies with blood work. A simple thing you can do, we sometimes talk about when we're not sure if somebody has MG, early stages, the ice pack test can be done. Historically, there was something called the Tensilon test, not done as often today. For electrodiagnostic testing, repetitive nerve stimulation, which is part of EMG testing, can be done. And about 75% of the time, we will see that fatigability, literally with repetitive use, repetitive stimulation of a nerve muscle connection. You can bring out that abnormality in a characteristic way. And that's how we use repetitive nerve stimulation to make the diagnosis. Especially helpful if somebody is antibody negative. And single fiber EMG as well, which is, we often say, the gold standard and helpful in seronegative MG in particular. Imaging scans, will not make the diagnosis, but we use them to rule out other things and to look for presence of thymoma, right? So a CT of the chest has to be done early in myasthenia to look for abnormalities of the thymus gland. So again, people will often present with double vision, droopy eyes, often at the end of the day when fatigued and tired. And these symptoms may occur with watching screens, or, when on devices. And the double vision at MG tends to resolve if you cover one eye. That's because you're taking the alignment issue out of the picture. And again, this double vision is not coming from the eye, it's coming from the muscles that move the eyes. So that's why for MG, covering one eye would resolve the double vision. And sometimes people will even wear a patch, but with modern treatments, our goal is to, reduce the need to do things like that. And as it progresses, there can be difficulty climbing stairs, which would be a manifestation of lower extremity weakness. Climbing stairs, even getting up from a chair, or from a seated position, from a sofa. Deeper sofas where people are way back, it can be, it may be difficult for anyone, but more difficult in myasthenia. Reduced exercise tolerance as well can occur. And again, this is fatigable weakness. It's generally not fixed muscle weakness. When severe and not treated, for many years or not adequately treated for long periods of time, the fatigable weakness can transform into fixed weakness, but it generally doesn't start with fixed muscle weakness. You see, note there, the MG-ADL is a great tool to track symptoms. And here displayed on the screen is the MG-ADL you're probably familiar with, but it's just a rating scale we use to track symptoms. It is validated and used worldwide. Validated meaning trials, studies have shown that it is pretty reliable, but we do have to remember it is subjective in the sense that it's self-reported, right? It's not a measure of strength. We have other rating scales that are a little, maybe even more objective. But this is a good way to track symptoms, and it looks at the 8 main symptom domains: talking, chewing, swallowing, breathing, use of the upper extremities measured by brushing teeth or combing hair, lower extremity strength is measured by rising from a chair, and then the 2 ocular domains, double vision and droopy eyes. If you have no symptoms, that's great. You get no points. That's normal. For mild symptoms, it's 1, moderate symptoms, 2, and for severe symptoms, 3 points. So the maximum score here would be like 24 points. Fortunately, most people generally don't have 24, but I often see patients with symptoms tracking to a 5 or 6, 7, 8, and our goal is really to get to a 0 or 1. We call that minimal symptom expression, which is a manifestation consistent with minimal symptom manifestations. Meaning, if you have an MG-ADL of 0 or 1, you're probably doing quite well. Minimal symptom manifestations. Okay, so what about the antibodies? There you're looking at a typical antibody as it would appear in a lab if you were doing research and looking and you were able to model an antibody. This is kind of what it would look like under a microscope and how it's modeled in software and, in computer software and so on. But yeah, the autoantibodies in myasthenia gravis, 80 to 85% are acetylcholine receptor antibodies. And the AChR antibodies, acetylcholine receptor antibodies, are more commonly found in men with MG, especially older men, middle and older aged men with MG preferentially have the acetylcholine receptor antibodies. There's another subtype you may have heard called MuSK. MuSK is actually much more common in women. There are men with MuSK, but it's actually quite rare. And LRP4 antibodies, we don't know if there's really a gender preference one way or the other, and these are very uncommon. 1% of the overall MG population has LRP4. And there's seronegative MG, probably a few more women with seronegative MG than men. And seronegative just means serum negative, right? It's the serum, the blood is negative, is where that term comes from. It just means that we haven't detected antibodies in the bloodstream. And again, that would then require clinical judgment and, electrodiagnostic testing to make the diagnosis. MG is uncommon. If we think about different common diseases across the country, what are common neurological disorders? Stroke, Alzheimer's, autoimmune disease in neurology, MS is the most common. MG is probably the second, we think probably the second most common autoimmune disorder that's neurological. And there's about 100,000 people in the USA with MG. And the prevalence is really going up. The incidence and prevalence is going up. Why is that? We're better at detecting it. There's more disease awareness, better at detecting it, meaning doing the antibody testing earlier. There's more disease awareness, in part because there's more new medications. So there's a lot of educational events and advertising and marketing and just more awareness, and this is key, the aging population. So MG is, somewhat relatively common. I mean, it's still rare, but relatively high incidence in middle-aged and older men. And so if we look at the aging population, that's and this is common in older men, you can see how then there's just going to be more cases. And we think the prevalence has doubled in the past 20 years. And again, this is due to all these factors: early detection, longer survival with the disease itself, and the aging population. As I've alluded to, there is this bimodal distribution, meaning 2 peak groups: younger women, roughly 40 and younger, and in the older age group, it's much more men than women. And people over 60, preferentially with MG, are more likely to be men than women. Taking a closer look here at comparing the genders. So again, as I've alluded to, the age of onset in men is quite common over, say, 50 and all the way up over 80 as well. We see new cases coming in. For women, tends to be younger. Again, there are exceptions. There certainly are exceptions to this, but there do tend to be more. For women, the average age of onset is typically under 40, not always. And antibodies, I've alluded to this, the acetylcholine receptor antibodies are more common for sure in men, and MuSK is rare. In women, AChR antibodies still way outnumber the MuSK, but there is more MuSK amongst women. For thymus imaging and thymus findings, thymoma, overgrowth of the thymus gland, or benign adenoma was called, or thymoma, is more common in men than women. But thymic hyperplasia, which is sort of a precursor to thymoma, that's actually more common in women. And the coexistence of other autoimmune disorders is less common with men and more common with women. Ocular myasthenia is more common in men. So primarily ocular manifestations, right? Double vision, droopy eyes, that's more common in men, less common in women. When it comes to severity, there really is no proven difference between the two. We see mild, moderate, and severe in both groups. Why are older men at greater risk for MG? There's a number of ideas looking at this, and certainly not, it's not all like proven or all worked out fully, but here are some of the leading ideas. So definitely dropping testosterone, hormonal changes with aging are believed to be part of this. So, testosterone has a little bit of an immunosuppressive effect. So as it drops, there's less suppression of autoimmunity, and thus more, if we lessen that suppression of autoimmunity, that means there can be more autoimmunity. And this protective effect being lost with aging then leads to a higher incidence of autoimmune disease, particularly myasthenia. And in general, the immune system is aging when we age, right? As we age. And so both men and women have a little bit greater likelihood of autoimmune disease as they age. This is just a bigger issue for men due to the lower testosterone levels, we think. And the thymus gland, the thymus gland plays a role in training immune cells, directing immune cells, what to target, hopefully not targeting self. But in older people, the thymus gland does not properly eliminate those immune cells that are targeting self. So if there is any residual thymic activity, the thymus gland is supposed to involute or kind of dissolve after birth, really. But if the thymus gland retains a little bit of function, then as we age, it may lose the ability to recognize self, basically, and therefore, make antibodies that target self. Also, late onset myasthenia in men is linked to some specific genes. This is not a one-to-one cause and effect. HLA-DR2 and B7, DRB1, those genes mentioned there are associated with a lot of different autoimmune disorders. So it wouldn't be like the kind of thing where you check those genes, and if you have those genes, you're going to get MG. No, but it's a slight increased risk factor. And it seems to be a little bit more in men than women. So all these things here are not causative, right? All men are having lower testosterone levels with aging. Most of them don't get myasthenia, right? All people are having what we call immunosenescence, meaning their immune system's aging. So we think these are factors, but they're not causative or one-to-one, correlations. And in MG with men, we see more bulbar and ocular symptoms. So I mentioned ocular alone is more common in men. Bulbar is as well. Bulbar refers to, like the bulb of the brain, really, even though it's kind of a misnomer, right? Because this is not a disorder of the brain. But the bulb of the brain stem, controls speech and swallowing. And so, that term has been used, perhaps we could argue incorrectly, but is used to describe muscle weakness of that affects speech and swallowing. And in MG, we say sometimes bulbar symptoms, meaning speech and swallowing difficulties. And this is more common in older men. There's often a diagnostic delay. People have in men, maybe even more than in women, actually, in MG. Why in older men in particular? Why might that be? Lots of ideas out there. There's always a differential diagnosis, meaning When someone has new symptoms, the doctor has to go through a thought process. Could it be this? Could it be that? And ALS is common in this age group too, in middle age and older men. And so I've seen a lot of cases over the years where someone was told they might have ALS and they turned out, to have MG, which is, of course, a much better disease to have, right? Because we have a lot of good treatments for MG. So there are some, we could say, biases or just, educational opportunities around the diagnosis. You can imagine too, grandpa's getting older, he's just slower getting out of a chair, or grandpa has cataracts, so he can't see as well. That's why his eyes are droopy. No, no, those things are usually not due to those other disorders and may in fact be signs of myasthenia. But so for those kinds of reasons, sometimes there is a diagnostic delay. And if we look closer at other related factors, so just some special notes there, we know that of the MG population, um, of older men, 40% have erectile dysfunction, 40% have anxiety or depression. Many in surveys report feeling withdrawn, socially not able to do as much. The disease itself can trigger loss of independence and feelings of loss of independence, has emotional impacts. These are all things that weigh in on either not diagnostic delay, quality of life, and just living with this disorder. It's not that MG specifically causes erectile dysfunction. There's no connection. But if you're a little bit weaker in general, it doesn't help. These things kind of feed off each other. And if you're having weakness, it can trigger emotional symptoms. If you have pre-existing anxiety or depression, having a diagnosis like myasthenia may exacerbate that, or make it a little bit, bring it to the surface. Okay, so thinking a little bit more now about how we manage this condition, the first thing is I've mentioned a little bit about earlier, the first thing we need to do is really confirm the diagnosis. Is the clinical history supportive? Is there reason to suspect MG? Clinical symptoms may mostly involve fatigable weakness, as I've talked about, right? So whether that's double vision or the bulbar symptoms or symptoms of the arms and legs, it's generally not fixed. The symptoms are fatigable, worse at the end of the day. And when we have that history, we're going to check the antibodies, acetylcholine receptor antibodies, MuSK antibodies, and LRP4. And most of the time, we make the diagnosis by blood tests, as I've mentioned. We do have to use electrodiagnostic testing in the seronegative cases. And then always early on, a CT of the chest should be done. A CAT scan of the chest should be done to evaluate for thymoma. 10 to 15% of MG patients have thymoma or hyperplasia. And everybody's going to get a trial, of Mestinon, pyridostigmine. The brand is called Mestinon. It's okay to use the generic pyridostigmine. And almost always we're going to use prednisone, at least a little bit. Most of us don't like to leave people on high dose prednisone long term. I don't like to do that. I don't do that really, but we're going to at least try, like a low dose, 5 to 10 milligrams minimum, and often up to 20 milligrams. At times we'll go to higher doses, but we have to look at comorbidities because prednisone can trigger all kinds of problems. It can raise the blood sugar, relieve the patient prone to infection. If you stay on high dose prednisone for long periods of time, there's increased risk of cataracts, glaucoma, osteoporosis. So we do have to be really careful with prednisone, but we're still often going to at least use like a low dose. It's available at every pharmacy. The patient can pick it up today and might feel better in a day or two. Long term, we have to think about biologics, meaning the newer therapies, the FcRn inhibitors, the complement inhibitors, the CD19 B cell inhibitors. We're going to talk about those all a little bit more. And the non-steroidal immunosuppressants, so Cellcept, azathioprine, or Imuran. And early on, too, it's important to provide some education and help the patient be an advocate for themselves. There's a lot of information out there these days, right? Things like what we're doing right now, right? These educational talks, and even Google has information. There's pamphlets, support groups, etc. And we want to be aware of what can trigger MG worsening, what can trigger symptomatic worsening. Certain medications can trigger worsening, and we're going to talk a bit more about that. Infection can trigger MG worsening. So we start early on. It's important early on to provide some of this education and stimulate more learning for the patient And an evolving thing that I'm doing, many of us are doing, is checking labs right out of the gate, early on for any exposure to hepatitis or tuberculosis, for example. Why? Because certain treatments require patients to be immune to those to move forward. So we want to get that additional information early instead of scrambling later. And same thing here with the meningococcal vaccines. So there's a move to try to get MG patients vaccinated early against meningococcal infection, because if they ever need a complement inhibitor, which is a category of treatment, and then you start the vaccination process, there could be this long delay while awaiting the vaccines. If the patient is vaccinated against meningococcal infection early, then if and when they need a complement inhibitor, they can start right away. All right, I've mentioned how there can be exacerbations. What do we mean by that? Probably familiar, right? But an increase in the fatigable weakness of any kind, we would call, if it's for a few hours, maybe we call, or a day or two, we might call that a fluctuation. If it's longer and more bothersome, an exacerbation. And MG crisis really means triggering, more problems with breathing, swallowing, ultimately worsening breathing. This scenario requires, a visit to the emergency department, because it can be, super urgent and lead to, if not addressed, and the breathing deteriorates, people can end up needing a ventilator, right? At least short term. So we really want to be aware of crisis, MG crisis. Again, that's when you develop the inability to breathe. And risk factors for crisis include uncontrolled disease, simply just not having well controlled MG. An infection. So patients who get an infection, pneumonia, that can trigger crisis. Chronic bulbar symptoms can also could also be a risk factor for crisis. So here's a more comprehensive list of the triggers of MG exacerbations broadly. So certain medications, classically, we see it a lot with Cipro or Levaquin. These are antibiotics. And you see on the side there a list of many other medicines. There are different lists of the medications that can trigger MG. Some of the lists are so comprehensive that you would think there's nothing you can take, So we want to be somewhat cautious. There's University of Michigan, University of Illinois. I'm here in Illinois. Some of the universities have nice lists. Actually, MGFA has a nice list as well. And it's, if we were to put everything on there that might have triggered an exacerbation in one person, one time, at one point, many years ago, we would have a list that was like 500 things long. So it's possible for anything to be a trigger, but here I've shown you sort of the main ones. You see their magnesium is on the list. So magnesium supplements are commonly taken. People use magnesium supplements for cramping or insomnia, headache, and that can trigger MG symptoms. So generally, I don't recommend taking magnesium in patients with MG. You see a list of other meds there, but amongst the antibiotics, the big one is levofloxacin or Levaquin and Cipro, because these are commonly used for antibiotics. For UTIs, as common antibiotics used to treat UTIs. So penicillin's okay, Keflex is okay, Augmentin is okay, amoxicillin is okay. Surgery. So any major surgery, yeah, that could trigger MG. So if you need a surgery, that's great, but that's okay to do that, but we just try to optimize your treatment going into that surgery. Stress, physical stress, so uncontrolled other diseases, COPD, heart failure, infections, of course, any stress are all representing in stress on the body. And also psychological stress can trigger MG symptoms. Again, any infection can trigger symptoms, and usually not mild infections, but flu, pneumonia, UTIs are big ones. And thyroid hormone abnormality. So people with abnormalities of their thyroid, if not properly addressed, that sometimes triggers MG symptoms. All right, so over the years there has been some evolution in treatment strategies. If we think back over time, and this is not a black and white, or binary situation. We still use the older drugs, but treatment goals have changed. Historically, goals were, prevent worsening, prevent crisis, keep people out of the hospital. Those are still very good goals. But in the modern era here today, we're really aiming and aspiring for our patients to have a normal or near normal quality of life. And, a state we would call minimal manifestations, meaning, no significant symptoms, maybe occasional droopy eyes, but no limitations. That's really our goal. And on the MG-ADL, that's manifested by or exhibit evidenced by minimal symptom expression, MG-ADL of 0 or 1. What's not captured by the MG-ADL, of course, is fatigue. But our goal is, for people to feel basically normal, near normal, have an independent life, high quality of life, and not be burdened with, excessive medication and excessive adverse effects from medication. So prednisone, for example, many people we can get to minimal symptoms with prednisone, but they might have to stay on 60 or 80 milligrams to get there. So we're looking for alternatives, right? We don't want to just leave people on medications that have lots of adverse effects. Immunosuppressants like Cellcept and Imuran, similar concerns. They do suppress the whole immune system. They're not really targeted or precision immunology at all. So the modern era, where we're looking at trying to reach minimal manifestation of symptoms as marked by minimal symptom expression on the MG-ADL, 0 or 1, without heavy duty, you know, um, carpet bombing, if you will, of the immune system. So our goal, as you see there on the bottom, is to do this, and we have the ability to do this using precision immunology, right? Targeted therapies give us the ability to see more benefit for the patient and MG, reach a normal quality of life without sacrificing all the, and then having all these adverse events. That's really our goal today. Are we able to do that for everybody? No, but much, much better options today than 5 to 10 years ago. All right, so here we're going to talk about now some of the treatments, and these treatments are used in men and women pretty much the same. There's no general rules of thumb that one works better for men or women or whatnot, but pyridostigmine, of course, or mestinon, symptomatic therapy only. So that's, usually, as I mentioned earlier, like the first thing that will be tried. How does that work? We'll get to that in a minute, but it basically just allows more acetylcholine to accumulate in order to compete with the antibodies to bind any available receptors. It's just treating the symptoms. Some people have a really good response. Often it's often not an adequate response. We use immunosuppressants, as I mentioned, kind of steroids like prednisone or steroid sparing agents like mycophenolate or azathioprine suppress the whole immune system. So they're not targeting any specific part of the MG pathophysiology or any specific part of the pathway here. They're just suppressing the immune system, so less antibodies and less inflammation. Targeted biologics. Okay, so these really changed the landscape quite a bit. We have complement inhibitors, we have FcRn inhibitors, we now have B cell therapy, some of which have been around a while, but now a newer one called Uplizna. And with complement, we have really like 3 different options now. And with FcRn inhibitors, we have 3 different options today. So pyridostigmine or mestinon, I've already mentioned a couple of times, but again, the way it really works is it inhibits or blocks acetylcholinesterase, which is an enzyme that would break down acetylcholine. So by blocking this enzyme, more acetylcholine accumulates in the neuromuscular junction. If you have more acetylcholine, then the idea is it can compete with the antibodies to bind any available receptors. But it does not modify the disease. It does not reduce the presence of antibodies or reduce the inflammation. It doesn't really do anything to modify or affect the underlying disease process. And as you may know, in higher doses of pyridostigmine, acetylcholine accumulation occurs in other places, the sweat glands, salivary glands, GI tract, so people can have, and muscles, so people can have twitching of the muscles, saliva accumulation, diarrhea. So there are some limitations with pyridostigmine, and it really has almost no limited efficacy, really no major benefits in moderate to severe MG. We can still use it, but we need something more. Corticosteroids, typically we use prednisone. And as I've mentioned, I mean, this is usually, not always, but usually at least somewhat effective, but it comes at a cost. There are just a whole slew of adverse events that occur with long-term use of prednisone. weight gain, diabetes, osteoporosis. It can affect mood, cause agitation, insomnia, actually can increase cardiovascular risk in a number of different ways, increases the risk of infection, fluid retention, glaucoma and cataracts. You can develop a muscle condition from taking prednisone long term at high doses called steroid myopathy. So we have to be careful. In low doses for short periods, it's still a great option we use, and it can help bridge people until other medicines are having an effect. But long term on high doses, caution. We want to be really careful. Also, I'll just mention, there are different dosing strategies with prednisone, so it's not a one size fits all. There's a lot of nuance, maybe a little bit of an art to it. And I would say the same thing about IVIG. There's different ways to dose IVIG. Actually, don't think I have a slide on IVIG today. We can talk about IVIG if you like, but IVIG is not approved as a treatment in MG. We use it, and it has been shown to have some benefits in studies, but it's not actually a standard approved therapy, and it is used primarily these days, more so with rescue therapy for someone in crisis or having an exacerbation, as opposed to maintenance. But similarly, corticosteroids are not specifically for MG. As I've mentioned, we use them, but we have to be careful with all these adverse events. Non-steroidal immunosuppressants. So I've mentioned mycophenolate and azathioprine. There are others that have been used. And all of these have been studied, but in small populations of patients. There's no large clinical trial. None of them are FDA approved. As physicians, we can use things that are not FDA approved. As long as they're approved for something and they're available on the market, we can use them, quote unquote, off label for conditions they weren't specifically approved for. But, it's better in general to use a medicine the way it would, after it was specifically approved for a specific indication, right? So that's one of the limitations right out of the gate. When it comes to azathioprine and mycophenolate, they've never really been proven in large trials. So we use them based on data from smaller trials and from our experience. We know that most people will have some response to these agents, but we want to be careful. Again, like prednisone, they suppress the whole immune system. They're not targeted therapies. They increase the risk of infection, malignancy, or cancer, skin cancers, particularly with mycophenolate, with long-term use. White blood cell count, other organs can be affected with chronic use of these medications, and they require lab monitoring. We have to monitor kidney and liver function and electrolytes and blood counts when we keep people on these drugs. Again, they're not targeted. So they can have a benefit for sure, and we still use them, but we want to be aware of these sort of pros and cons. Long-term use is associated with some adverse events. And unfortunately, as well, there's a large number of people, in my experience, 20, 30%, who really don't have that much benefit either. So there was a lot of unmet need if you go back 10 years ago, quite a bit of unmet need because all we had was prednisone, non-steroidal immunosuppressants, and IVIG. Okay, so the first biologic to come to the market for MG was Solaris, and that is one of the complement inhibitors. Still available, but we have some alternatives as well today. And so what's complement? Why would you want to inhibit complement? I think this is actually an area that there's a lot of educational opportunity. I've found a lot of even doctors don't really understand this fully, and often patients don't understand this, and that's okay. But so let's talk a little bit about it. So acetylcholine receptor antibodies. This is a unique thing. This is not true for MuSK, but the acetylcholine receptor antibodies activate the complement cascade. Complement is like a group of proteins in our immune system that our body has to fight off foreign bodies, to fight off certain pathogens. And it shouldn't be activated, in an autoimmune disease because there's no foreign pathogen, right? But mistakenly and through mishap, acetylcholine receptor antibodies activate complement. And this cascade of proteins, once activated, leads to deposits of complement proteins on the muscle membrane. And this leads to damage in the receptors, loss of the receptors, flattening out of the muscle membrane. So in animal studies, it's been shown actually that if you give them myasthenia gravis and then block complement, they almost appear normal. So when that was known, people began to think about, my gosh, we should try to use a complement inhibitor in myasthenia. And that led to Soliris, Ultomiris, Zilbrisk. Bkemv is just a biosimilar of Soliris. But the idea is by specifically blocking complement protein C5, and all three of those medicines do that in a similar way, by blocking and binding up C5, you don't get this complex, what's called a membrane attack complex. You don't get this complement deposit forming on the muscle membrane. You protect the muscle membrane from damage, and the receptors are saved. So that is the idea behind complement inhibition in MG. However, when we block complement, there is an increased risk of meningococcal infection, and everybody needs to get vaccinated. As I mentioned, because this is an important treatment strategy, it's generally an evolving area, but most of us are starting to try to vaccinate, if patients are agreeable, vaccinate with meningococcal vaccines early in the diagnosis process, early in the treatment algorithm, so that if they ever need one of these complement inhibitors, they're good to go. Because otherwise, we have to get people fully vaccinated to start a complement inhibitor, and that takes it takes about 6 months. If you're not fully vaccinated and you're starting a complement inhibitor despite not being fully vaccinated, then we generally would recommend an antibiotic prophylaxis, with penicillin typically. So that's the backstory on complement inhibitors. That's why they can work. There are three, there are four kind of available today. And here's just one example. This comes from, I found this on Google. There's all these companies have a lot of slides, but I'm not using anything I got from, not using any slides from companies, but a lot of this is just on Google Images, and this is an example from Ultomiris, which is a long-acting complement inhibitor. Gray represents placebo, green represents the treatment group in their trial, and the Y or vertical axis is looking at the QMG, which is a rating scale like the MG-ADL. And there's similar data if you look at MG-ADL, QMG, or other rating scales. But what you see is improvement, a drop in the score, as represented there in green for the treatment group. The symptoms improve quickly within the first few weeks on average. The trial there you're seeing lasts 26 weeks. That's the randomized controlled period. And then after the trial is open label extension, where the placebo patients are crossed over. The patients who are on the study drug continue on the study drug. And everybody's on Ultomiris in this case. And you see this improvement is sustained, and in fact gets to be a little bit better over time. In this particular slide here, this is data out 3 years that the benefit of Ultomiris is sustained and gets better a little bit with time. There's not like an off period or up. There's no ups and downs. They kind of just slowly get better, quickly get better, and a little bit better yet over time. So again, gray is placebo, and then red is the placebo patients crossing over in the open label extension where everybody is on study drug. So when the patients who are on placebo cross over to Ultomiris, they have the same benefit. Just an example, same data is seen with Soliris, with Bkemv, with Zilbrisk, and so that is the basis for using complement inhibitors in MG. Okay, FcRn inhibitors. So the second biologic was Vyvgart, and with Vyvgart we have three options. Vyvgart prefilled syringe, which is self-administered. Vyvgart Hytrulo, which is administered by a nurse, healthcare provider, or IV Vyvgart, through the IV. And we also have Rystiggo, and we have Imavi. The mechanism here for all three is blocking FcRn. Why FcRn? You might wonder, what the heck is that? FcRn is the name of a receptor that extends the half-life by recycling these antibodies, recycling IgG antibodies. AChR and MuSK and LRP4 are a type of IgG antibody, autoantibody. And if we block the recycling pathway, basically you can think of these antibodies then having no way to extend their lifespan. They get brought to what's called a lysosome. They get brought to the lysosome where they're destroyed. So if they're not recycled, they get taken out with the trash, you could say. And so an FcRn inhibitor, all three of the available FcRn inhibitors, will lead to markedly reduced levels of the pathogenic antibodies. And as those antibody levels fall, patient symptoms should improve. That is the idea. So Vyvgart and Rystiggo are given through cyclical therapies. Vyvgart, there are ways to actually give it every 2 weeks, or you could even conceivably use it every week these days. But classically, it was studied initially as a cyclical therapy, meaning like 4 weeks on, 4 weeks off, 4 weeks on, or even 6 weeks off, or 8 weeks off. It comes with this flexibility where you repeat the cycle as needed or as indicated. Rystiggo is given through a sub-Q pump, 6 weeks on and then 3 weeks off. So a little bit more intensive schedule there. For some patients, that's exactly what they need, right? And then again, you would repeat the cycle as needed. So Mavi is unique in that it was studied in its trial as a continuous therapy. It has very high affinity binding for FcRn. So in being tightly bound to FcRn, it blocks the recycling pathway and it can be given in this way effectively. So it's just every 2 weeks. There's no off or break period, and it's only IV. So with all the FcRn inhibitors, some good antibody is removed from the body as well. And so there's no meningococcal infection risk specifically, but just in general, we have to be aware of the risk of infection, all kinds of infections potentially, but upper respiratory tract infections and UTIs. Haven't seen, cross our fingers, a lot of infections. Most people do pretty well with the FcRn inhibitors. Here's an example. Again, we could look at similar data. We're doing a comprehensive talk today, not targeting, not specifically talking about one medicine. But here is data shown from Mavi, just looking at the antibody level drop. So you see in blue, the placebo patients. Again, this is available on Google. It's not from the company or anything. And red is showing the Mavi patients. So blue is flat, that's placebo. It's flat, meaning there's no drop in the antibodies. The patients given Amavi pretty quickly there have a marked drop in their antibody level, and that's sustained in the trial for 24 weeks. With the cyclical FcRn inhibitors, you'd see something similar, but a little more up and down, right? Because they're given in a cyclical fashion, unless maybe you tried to give them, continuously, then you might see something similar. But 75% drop there in the antibody level, and that's sustained in their trial for 24 weeks when given IV Q2 weeks, every 2 weeks. Here's a little bit of data from Vyvgart. Again, this is on Google. I'm not using slides from any of the companies directly or specifically. And this is Vyvgart. So you're looking there at the MG-ADL. This is not the antibody level, although you would see a similar slide if we wanted to look at antibodies. Here we're looking at just the improvement in MG-ADL. So purple is Vyvgart. Gray is placebo. In any clinical trial, there's always symptomatic improvement with placebo, that at least a little bit, and you see that with Vyvgart, but you see much more improvement with Vyvgart compared to the placebo. 2.5 times more benefit with Vyvgart over placebo by week 4. And again, we would see similar data if I showed you Rystiggo or Amavi. And then in the off or break period, you see, the MG-ADL does start to go back up a little bit again. So then you would do another treatment cycle. All right, so looking at B-cell therapy. So we've had B-cell therapies for decades, right? Rituximab has been around for a long time. There are some other agents that kind of inhibit B cells, but rituximab is the one that's primarily been used when we were targeting B cells specifically. It's a CD20 positive B-cell inhibitor. And the idea is to reduce the production of antibodies. I mean, again, as far as we understand MG, the antibodies underlie this disease. They cause complement activation and so on, but it's not something else. It's really the antibodies themselves that mark this disease, right? So rituximab is a CD20 positive B cell inhibitor. Turns out the AChR and MuSK antibodies, though, are really, those autoantibodies come from plasmablasts and plasma cells that are CD19 positive. So rituximab doesn't specifically target the cells that produce these antibodies. And so we think that's maybe why we haven't seen, broadly speaking, like conclusive evidence in large clinical trials for rituximab. Maybe for MuSK, we've seen strong data for rituximab in MuSK MG, but not acetylcholine receptor antibody positive MG in trials. Enter Uplizna. So Uplizna specifically did a trial looking at AChR and MuSK patients, and Uplizna specifically does target CD19 positive B cells, which are the ones that make AChR and MuSK antibodies. And in their trial, interestingly, they included prednisone tapering. meaning while patients were given Uplizna, they were directed to reduce their prednisone, and they still had benefit. So that's kind of a cool feature with Uplizna. Thinking about other medications, I just wanted to throw out there the pipeline is strong. There are a lot of new medications being studied. There are other types of complement inhibitors being investigated. There are still other FcRn inhibitors being investigated. There's something called CAR T therapy, where you target DNA or RNA to basically stop signaling B cells to make antibody. So in blocking this, less antibody would be produced. Some promising data there. There's something called telitacicept, which is being developed. There's a large trial being done today that's enrolling now, and there's some positive data, but it was all from study sites in China so far. So there was some concern that some of the data, we don't know for sure how that data was fully collected and so on. So a large trial is being done in North America now, and that will help us get more information on telitacicept. And here is just a little bit of, again, from Google, a little bit of data visually showing you what happens with Uplizna. So in the MINT trial, which was the trial for Uplizna, it does take a little longer to kick in. You don't see any separation between Uplizna and placebo in the first 28 days, but by day 29, while steroids are being tapered, in those weeks and months that follow, going out to day 183, which is like half a year, you see more benefit. Again, this here is the MG-ADL. You see more improvement on MG-ADL for patients treated with Uplizna versus placebo. And this is while their prednisone is being tapered. So similar kind of data was shown with telitacicept and some other evolving therapies that affect receptors and signaling that ultimately signals B cells. So as I say, B cells and beyond, there's something called APRIL and BAFF. These are signals that are sort of adjacent to the B cells. And so similar effect is being looked for and explored with other agents, but with Uplizna currently available, we have this therapy now. You can see benefit while tapering prednisone early on. All right, so we're coming to a summary slide. Look, much of what I said pertains to men and women. There's each individual. We talk about MG as a snowflake disease often, and it is an individual disease. Everybody's different. Every man, every woman, every case is different. But tried to highlight some of the issues that pertain to men specifically. MG is increasingly recognized in older men. I'll tell you, if you go back 20 plus years ago, when I was in medical school 25 years ago, it was thought of as more of a young women's disease. And I think that's definitely changed. The incidence and prevalence has gone up quite a bit in men. Again, as we talked about, better detection, but also aging population. We're getting better at diagnosing this. When it comes to other aspects of men's health, I'm just going to mention, we didn't get into this too much, but there is no effect of MG on, the prostate or prostate cancer. I did mention erectile dysfunction is common in older men and common in MG patients, but it's not, caused by MG per se. And again, the key issue there with the incidence and prevalence is that it is definitely higher in men than people used to think. And that's primarily men over 60. We talked about some similarities and differences between men and women. Men are more likely to have AChR antibody positive MG. Women have a lot of that too, but there's more MuSK amongst women and less MuSK antibody positive MG in men. Thymoma is a higher incidence in men versus women. We talked about treatment goals, which are more or less the same, right, between men and women, with men and women. We want normal function, not just preventing relapse or crisis. We definitely want to prevent crisis, but we want to do better than that. And we talked about all the different therapies from the Mestinon, which has been around since the 1950s, to, of course, these modern therapies, as we just discussed. The newer options are now being added on to older therapies and also used in lieu of older therapies in many cases. And they assist with allowing us to taper prednisone and maybe in some cases even get off some or lessen the need for non-steroidal immunosuppressants. And the other area of evolving treatment guidelines hopefully in the next year or so will reflect this, is the idea that with more aggressive treatment earlier on, we can prevent disease progression. And that brings us to the close. Here are just a few of the references listed, and I have time to take some questions. I appreciate everybody sticking with me here through most of an hour.
Awesome. Yes, if you have any questions, go ahead and throw that in the Q&A. We did have a question early on, which I think was answered about decreasing testosterone. So if you have any follow-up questions related to that one, please resend. And then we do have a question related to nutrition. They've taken CellSat for 2 years, and I've been pharmaceutically in remission for 2, and are attributing that to changes in diet over about 3 years. So, how significant do you believe nutrition is within the treatment of MG
Yeah.
patients?
Right. There's not a lot of strong data on this topic, but generally, if we extrapolate from what's known in other conditions and other research, and I think what you're getting at, the person asking this, I think knows this, but maybe the rest of the audience we can provide a little more insight. There's foods that we think are inflammatory, right? Certain things can be inflammatory, like lots of meats and butter and things that might have been, if there might have been hormones or used in production, or GMOs, or right, these mass-produced foods are likely more inflammatory. This is an evolving area, and if you're eating a lot of foods that are inflammatory, guess what? That may be a trigger to the immune system to make autoantibodies or trigger other processes. Maybe a good thing a good kind of example too of where understanding is advanced and it relates to diet is something called celiac. You hear of people going gluten-free, right? Gluten-free is a less inflammatory diet. We think that wheat in celiac, for example, this is sort of a case study in a sense. Wheat is literally inflammatory to people with celiac and causes all kinds of havoc in the GI tract. So that's kind of the idea, the model behind this idea that like certain foods are inflammatory, and therefore if you cut them out, you'll have less inflammation and you may fare better with an autoimmune disease. But it's still being worked out and it's not fully understood. But yeah, so if you went low inflammation, adopted a less inflammatory diet, maybe you take probiotics, try to eat natural fruits and vegetables, fish, and that kind of overlaps too with the Mediterranean diet, another diet that's kind of a hot topic. Eating healthy, broadly speaking, and less artificial stuff, probably has benefit, but it's sort of not fully worked out yet.
Awesome, thank you. And as of right now, I don't see any other questions popping in. So I want to thank you for your presentation. I really appreciate it. And if you, oh, wait, we might have one. You said that men with big thymus are more likely to have thymoma. Um, about scar, or about scar percentage of us will. About
10 to
what percentage?
15% of patients with MG have a thymoma, and there's more men with a thymoma than women. And yeah, those are the facts there.
Yeah.
Um, if you have an enlarged thymus gland, that's abnormal by definition. And once in a while, someone is found to have an enlarged thymus gland on a CAT scan done for other reasons, and they don't even know they have MG. I've had patients come to me that way, and then it's sort of like you're expecting them to develop symptoms, unfortunately, right? Because so overgrowth of the thymus gland would always be abnormal, but and is related to MG, we think, but most patients with MG, if you do a scan, their thymus gland looks normal. Now, we know that removing the thymus gland, even in people who have a normal appearing thymus gland, can give a better outcome, maybe even induce remission, but primarily that's thymectomy, thymus surgery when there's no thymoma, just prophylactically, preemptively removing the thymus gland primarily has benefits in patients under 65. If we just remove everybody's thymus gland with MG, there's risk of complications, and those risks are higher in older people. But I didn't mention that is also a treatment option for younger people with MG would be to just remove the thymus gland.
Yeah. I knew there used to be more research supporting that in females, and it was less done or less, I guess, normalized to also do that in the male
Right.
population. So that's good
Correct.
to know.
Yep.
Awesome. Well, thank you again. We are hitting that time frame. So again, we appreciate you. And as always, anyone out there, if you need support or resources, reach out to us at www.mgassociation.org. All right. Thank you.
Thank you, everybody.